So today we'll be dealing with immunity. Immunity is actually, in simple words, to explain, it is a capability of the body to fight against the foreign antigens or microorganisms. So to define it, it is a balanced state of maintaining the adequate biological mechanisms to fight against infections, microorganisms, or other the invading substances which are harmful to our body. So immunology is a study of these molecular as well as the cellular functions which are involved in the process of immunity. Immunity is broadly divided into two phases, that is the adaptive immunity and innate immunity. Innate immunity is also known as native immunity, that is being adapted from the childhood, that is from the birth. Whereas adaptive immunity, it is being acquired, it is an acquired immunity where it progresses during as the life grows on. So further, this adaptive immunity is being further divided into natural immunity and the artificial immunity. Natural immunity is the immunity which is being obtained naturally from the body defense systems, whereas artificial, when we are being exposed to certain antibodies to fight against the antigens or the foreign antigens or the microorganisms, that is known as artificial immunity. So then further, this natural immunity could be a passive immunity or the active immunity. Passive immunity, which is being obtained from the mother, that is from the maternal, during the transplacental exchange of the fluids or otherwise the antibodies. This immunity is being attained, whereas the active immunity, that is the natural, that is the acquired natural immunity in the active phase, is being attained when the host is being exposed to infection. Then this immunity starts developing and shows its action. Coming to the artificial immunity, artificial passive immunity usually occurs when the antibodies are being transferred to the host immune body, whereas that artificial immunity, if it is an active immunity, then it is by the immunization. For example, illustration can be given of a tetanus toxoid, which is being exposed to the human body when there's any injuries to fight against the toxins which are being attained from the bacteria or further other organisms. So this is what an immunity is. That is, one is the adaptive immunity and the innate immunity. Usually, innate immunity is not specific, has an antigen specificity, whereas the adaptive immunity has an antigen specificity. And innate immunity has been developed before microbes attack the body, whereas adaptive immunity is being stimulated or activated once the microbes only start affecting the body. So this is what is the broad classification of immunity. Coming to the immune system comprises of certain organs as well as the cells. And these organs, they could be the primary lymphoid organs or the secondary lymphoid organs, whereas the cells, they are various other cells. Coming to the primary lymphoid organ or the thymus, this is the largest organ which is present in the body, one of the largest organ. And this thymus, it usually involves in production of activating the immune system by creating an inducive environment for the T cells to differentiate and further development. This serves as a function as immune system, thymus. Next comes the bone marrow. This is a tissue usually present in the interior part of the bone. And this bone marrow, it is usually provides an environment where the T cells usually differentiate from the precursor cells. This is what the function is of the bone marrow. Other than the functions of the bone marrow in immune system, it also helps in production of new red blood cells, that is known as hematopoiesis. Coming to the secondary lymphoid organs, starting with the lymph nodes, these are the organs or the tissues which are being widely distributed throughout the body, and they are function in respective to the region. And lymph nodes, they are usually have a function in usually in adaptive, that is the acquired immune system. They also involved in production of the T cells as well as the B lymphocytes. Coming to spleen, it is structured in similar in morphology to that of the lymphocytes. Usually, it helps as a barrier by filtering the older red blood cells and acts as a reservoir for the blood vessels, and it helps in production of mast cells, T lymphocytes, and other immune system cells. Coming to malt, it is a mucosa-associated lymphoid tissue. Usually, it is diffusely present throughout the body. They appear in the form of concentrations in mucosal sites of eyes, skin, glands such as lacrimal glands or salivary glands, and even in the gastrointestinal tract. So, this malt, it is involved in production of macrophages as well as for a few lymphocytes which are responsible for maintaining the immune system. So this is what are the organs of the immune system. Coming to the cells, they are the first line of cells, that is the lymphocytes. Then comes the monocytes and the macrophages. Then comes the basophils, neutrophils, mast cells, and eosinophils. Coming in brief to the cells of the immune system, starting with the lymphocytes, they are the first line of defense cells. They can be categorized into three groups, that is B lymphocytes, T lymphocytes, and the natural killer cells. Further, these T lymphocytes are being categorized into two groups, that is the T helper cells, also known as T regulatory cells, or T suppressor cells, or otherwise known as cytotoxic cells. Starting with the B cells, they usually constitute 10 to 15% of the total immune system cells, and they are usually the major function is to provide that is produce antibodies. These B lymphocytes usually they activate when an antigen comes in contact with the B lymphocytes. This activates the B lymphocytes, and this gets differentiated into a plasmacytoid cell, and this plasmacytoid cell further differentiated into a plasma cell, which produces the antibodies. These antibodies usually function in protecting the body by fighting with the against the antigens, respective or specific antigens. Coming to the T lymphocytes, these T lymphocytes are usually involved in protecting the protecting a body by producing two types of cells known as T helper cells and T suppressor cells. T helper cells usually enhance and regulate the immune system. They fight against the foreign antigens by producing the helper cells. That is, they help the body. Whereas T's, as the name itself suggests, coming to T suppressor cells, they do not enhance or regulate the immune system, but directly they affect the invading antigen. That is, they destroy and lyse the antigen. And further, these T helper cells and T suppressor cells, they attain an immune and genetic influences by which are being denoted by a by specific molecule known as cluster of differentiation. This cluster of differentiation is a molecule which is being attained, which reaches to the surface of this T helper cells and T suppressor cells. Usually, these cluster of differentiation are of two types, that is the CD8 plus cells and CD4 plus cells. The T helper cells are being denoted with the presence of CD4 plus cells. They are usually 60% of the total cluster of differentiation cells amongst the ratio of CD4 plus cells and CD8 plus cells, whereas the T suppressor cells are being denoted by the expression of CD8 plus cells. And coming to the ratio of CD4 plus cells and CD8 plus cells, CD4 plus cells are usually twice the ratio of the CD8 plus cells. So this is what is the function of T lymphocytes. Coming to the natural killer cells, they are usually 10 to 15% of the total number of cells in the immune system, and usually in the natural killer cells, they actually directly invade the antigen by producing a cytotoxic effect. So these cells are known as antibody dependent cell mediated cytotoxic cells. Coming to the next set of cells known as neutrophils, which are the major constituent of the immune system, which have a total of which comprise a total of 40 to 75% of the total body. And coming to the next set of cells, they are the monocytes and the macrophages. They are approximately 5% of the cells. And next, coming to the eosinophils, which constitute 1 to 6%. And the last cells, which are of the least ratio, are the mast cells and the basophils, which are up to 0 to 1%. Coming to the function of the mast cells and the basophils, usually they have a surface receptor, or otherwise known as surface immunoglobulin, or antigen also could be say. It contains immunoglobulin E antigen. This immunoglobulin E antigen mainly functions as a receptor. When tissue is being exposed to an antigen, this antigen comes and binds to this immunoglobulin E receptor, and this immunoglobulin E receptor, usually the function of a receptor is to progress the intracellular mechanism. So once the antigen comes and binds to this immunoglobulin E receptor, then the intracellular mechanism starts activating. That is, this results in the release of the mast cells, which contains mast cells and basophils, which actually contain certain granules which mediate the inflammation. Also contain histamine and heparin. The few of them are vasodilators. They also release certain vasoactive amines. All of these mediate the inflammation, also help in wound healing, thereby promoting the immune system. So this is what is the function of the mast cells and basophils. Next, coming to eosinophils are usually get activated. They also constitute the same IgE receptor on them, which on a combination with an antigen starts promoting its function by releasing certain lysosomal enzymes. These lysosomal enzymes usually cause the degradation of the antigen by causing the lysis. They also contain other enzymes known as peroxidases, which are also involved in fighting against a foreign antigen. So coming to the next set of cells, that is the monocytes and macrophages. Usually Monocytes are the cells which are the circulating macrophages. So these cells usually they circulate in the body fluids for a lifespan of 3 days. Once they circulate in the body fluids and they reach the macrophages, they become the macrophages once they enter the tissue. So these macrophages has a specific function known as antigen recognition. That is, they recognize the antigen by coating the antigen with a specific antibody to that antigen. That is, opsonization occurs. That is, coating of the antigen with the antibody is known as opsonization. This is the first phase of function of the macrophage, that is the antigen recognition. Once the antigen has been recognized, it starts phagocytosis. That is, it starts engulfing the cell by process known as cell eating. Then this antigen gets eaten up, and then after eating the antigen, the macrophage turns into an antigen presenting cell. That is, as this phagocyte contains the specific antigen as well as the antibody within it, it starts making it as an antigen presenting cell. That is, based on the presence of the major histocompatibility complex, that is the complex which is usually required for the activation of the specific D or otherwise T cell or the B cell. This antigen presenting cell, it contains the major histocompatibility complex as well as the specific class 1 or class 2 or class 3 MHC complexes. Once these complexes are getting activated and there is expression of these complexes, they reach the specific cell where they have to be further lysed. That is, it can reach the T cell or the B cell. Once they reach the T cell and the B cell, the further process of degradation starts. This is what happens. This is what is a major function of the macrophage. That is the antigen recognition, phagocytosis, and act as an antigen presenting cells and further reach their respective cells, that is the T cells or the B cells, for the further degradation and maintenance of the immune system. Coming to the neutrophils, these are also the cells which usually have certain granules within them. When these cells get activated because of an antigen, on exposure to an antigen, they release the enzymes are known as lysosomal enzymes which are present within them, and they cause the lysis of the invading antigen. This is what is the function of specific functions of the cells of the immune system. Coming to the B lymphocytes versus T lymphocytes, usually majorly the origin of this B lymphocytes and T lymphocytes is by from the B cells. They are originated from the bone marrow, that is from the bursa. So they are termed as B lymphocytes or otherwise bursa lymphocytes. They are so termed because bursa lymphocytes, because they were first identified in a fowl known as bursa. So they are termed as B lymphocytes. And the next, coming to the T lymphocytes, the origin of the T lymphocytes is usually from the thymus. So they are termed as T lymphocytes. And coming to the lifespan, usually the lifespan of the small T lymphocyte is from several months to years, whereas the blast T lymphocytes is for several days. Coming to the B lymphocytes, that is a small T B lymphocytes, the lifespan is of 1 month, whereas the blast, it is for few days. Coming to the location, they are usually present in cases of when there is exposure to the antigen, and they are usually present in the circulation also. The specific markers for surface markers for T lymphocytes is the CD4 plus cells and CD8 plus cells, and also based on the division of the T lymphocytes into T suppressor cells or otherwise T help regulatory cells. And coming to whereas the B lymphocytes, they contain specific immunoglobulins within them. Coming to the major functions of the B lymphocytes and the T lymphocytes, usually T lymphocytes, once they are exposed to the antigen, they start showing the function and they further differentiate based on the function. It could differentiate into T helper cell or otherwise the T suppressor cell. Whereas the B lymphocytes, once it major function of the B lymphocyte is to differentiate into a plasma cell and further produce antibodies which act against a specific antigens. This is what is the function of the B lymphocytes and the C lymphocytes. Coming to the major function, how the B lymphocytes act actually. When a B lymphocyte is being triggered, that is when a specific matching antigen is being exposed to this B lymphocytes activate. Once the B lymphocytes gets activated, it engulfs this antigen and further it digests. That is, phagocytosis process starts initiating in the next step. Then after the phagocytosis occurs, as the B lymphocytes contain the antigen within them, then it displays the antigen fragments, that is, they are they express the specific major histocompatibility complex, and once this major histocompatibility complex is starting being expression, then there's combination of this antigen along with the major MHC factor. This combination of the antigen and the MHC factor, they start attracting the T lymphocytes. Once they start attracting the T lymphocytes, these T lymphocytes secrete cytokines. That is these cytokines, they usually help the B lymphocytes to multiply and further produce further differentiate into the plasma cells and start producing the antibodies. So this is what happens once the B lymphocytes recognizes the antigen, phagocytosis occurs, it attracts the T lymphocyte and then releases the cytokines. These cytokines help in production of the antibodies. But once the specific antibodies are being formed, then these are released into the body which fight against the respective antigen, and they form, once they recognize the specific antigen, they form the antigen antibody complex. This antigen and antibody complex, they activate the complement cascade reaction, that is, which are involved in removal of this antigen antibody complex. If this specific complement system is not being activated, they are removed by the liver and spleen, which are actual barriers for the immune system. This is what is the major function of the T cell. Coming to the T cell, usually a T cell, it is usually fixed, but once it gets exposed to the antigen, it causes mobilization of the T cell occurs. That is the movement of the T cells from its specific site occurs. The first picture, as it shows, that is the antigen on exposure of the T lymphocyte to the antigen, it starts its movement, that is, it attains a stage of motility where they encounter a cell such as a dendritic cell or the otherwise the B cell that has that adjusted antigen within it, and it starts displaying the antigen fragments which are bound to the MHC fragment, as we have seen in the B cell activation. That is, once an antigen is being attached to this specific lymphocyte, then there will be an expression of the major histocompatibility complex. Once there's expression of this major histocompatibility complex, then the T lymphocytes start releasing the chemokines, or otherwise the cytokines, which are the chemical mediators of inflammation. These cytokines, when they are being released, then that means they help in the maturation of the T cells. The major function of the cytokine is to mature the T cells. So on releasing these cytokines, the T cells start maturing. Then the MHC antigen, that is a major histocompatibility antigen, it complex, it activates. Then the T cell receptor and the T cells, they together secrete the cytokines. Once these cytokines are being secreted, some cytokines, what they do is they stop or they pause the growth of the T cells. That is, the maturing of the T cells is being further ceased. Otherwise, these cytokines, what they do is they get attached to the infected cells, and once they get attached to the infected cells, these cytokines, these T cells, they differentiate into the helper cells or the suppressor cells. These helper cells, they further secrete the cytokines and they attract the fresh macrophages. That is, once these macrophages are being attracted, they cause the macrophages, along with the macrophages, the other neutrophils and leukocytes, they start attracting to the C cells which have secreted the cytokines. Once they get attracted, they recruit the arrival of these cells to the further process of degradation of this antigen presenting cell. And otherwise also the T cells, they might become, if that is what happens in T helper cells, that is the cells which regulate the immune cells. Whereas T cells, when they start expressing the specific major histocompatibility complex, which differentiates them into the T suppressor cells or the T cytotoxic cells, they directly cause the invading the antigen. This is seen in cases of infections with viruses. This is what is the function of the T cells. Coming to the innate immunity or the adaptive immunity, innate immunity, which is being usually the immunity which is being attained before there is any exposure to the antigen or the microbial. So usually innate immunity is attained by certain cells such as Langerhans cells, or which are dendritic cells usually present within the epithelium. These cells, they get activated when there is any antigen trying to induce within the epithelium. So once the antigens tries to induce within the epithelium, these dendritic cells or the Langerhans cells, which are a type of cells which are involved in the innate immunity, they start reacting with this antigen. That is, they carry this antigen into the deeper levels of the tissue, where they get these cells usually in the epithelium are immature Langerhans cells. But once they travel carrying this antigen into the deeper tissue, they start maturing, and this mature cell results in the causes reaches to the lymphocytes, lymph nodes, specific lymph nodes, such as the regional lymph nodes, and they causes the phagocytosis of the engulfed antigen. This is being mediated by the complement cascade pathway, as well as with the help of other set of cells known as natural killer cells. This is what happens in innate immunity. Coming to the adaptive immunity, we usually it could be progressed by the B lymphocytes or the T lymphocytes based on the expression of the major histocompatibility complex. So if it is being involved, if the MHC factor shows its expression which belongs to the B lymphocytes, then this B lymphocytes along with the attached antigen, moving by releasing the specific once this B lymphocytes, they engulf this antigen, they attract the T lymphocytes, as we have seen in the previous slides, that these T lymphocytes further release the cytokines and cause the degradation of the foreign antigens with the formation of antigen antibody complex. Whereas in T lymphocytes, we see that once this antigen T lymphocytes is being recognized with the antigen, it mobilizes, and this mobilized T antigen releases the cytokines. This cytokines further differentiate based on the specific receptors into T helper cells or the T suppressor cells, where the T helper cells, they enhance and regulate the immune system, whereas the T suppressor cells, they directly cause the cytotoxic, they show the cytotoxic activity and destroy the foreign antigen. This is what happens in an adaptive immunity, differentiating the B cells, functions of the B lymphocytes and the T lymphocytes. Coming to the humoral immunity and the cell-mediated immunity, it is called humoral immunity because the cells are not involved rather in the humoral immunity, but rather the humor, that is the fluids of the body, they are involved in the immunity. These fluids which carry the immune system cells. Whereas in cell-mediated immunity, we see that the cells which are involved in the cellular cells, that is the cells which mediate the immune system, which could be the monocytes, macrophages, eosinophils, mast cells, base cells, or otherwise natural killer cells, or the set of lymphocytes or their population. Usually they are involved. So it is known as cell-mediated immunity, and otherwise it is known as humoral immunity because it is being carried out by the body fluids. Coming to what happens in a humoral immunity, when there's extracellular microbe, as we can see in the picture, there's exposure to this extracellular microbe, say about giving an illustration of bacteria, then the B cells get activated. These B cells usually have specific receptors upon these cell surface, and these receptors, once they get activated, they differentiate it into plasma cells and they start secreting the antibody. This antibodies, once they get attached to a specific antigen, they form the antigen antibody complexes. These antigen antibody complexes, they are being neutralized by the complement cascade activation. Once they are being neutralized, they do not get directly lysed by the cell, that do not damage the cells directly, but rather they neutralize them and they cause the lysis. They bring the degradation of this antigen antibody complex, and then these lysed products are being phagocytosed, that is, they are being engulfed by the macrophage cells. This is what happens in humoral immunity. Whereas coming to the cellular immunity, we see that once there is the exposure of the antigen, that is the intracellular microbe, then this becomes in an adaptive immunity, cellular immunity, we see that the cells, respective cells, they engulf this antigen and form an antigen presenting cell. This antigen presenting cell is being further, it differentiates into, based on the processed and the presence of the antigen, it differentiates into either the T helper cells or the T suppressor cells. These T helper cells, as they contain the specific receptors, that is the CD4 plus cells, they release the cytokines, and these cytokines usually attract to the receptors which are present on the cells of the T lymphocytes, and they cause the activation, proliferation and activation of the effector cells, that is the T cells, and they cause the lysis of the infected cell and result in phagocytosis. This is what happens in the cell-mediated immunity. And the cells, dendritic cells, which are present within the epithelium, they are immature cells and they are known as Langerhans cells. When an antigen is being adapted to an epithelium, then this antigen is being captured by this immature dendritic cell or the Langerhans cell. So once this antigen is being captured by this dendritic cell as being shown in the picture, then then there is release of the cytokines. By the release of the cytokines, there is loss in the adhesiveness of the dendritic cells. By the loss in the adhesiveness of the dendritic cells, these dendritic cells, they detach from the adjacent cells and start moving to the intracellularly, that is to the deeper tissues of the connective tissue. This is because the receptors here in the dendritic cells are activated by the release of the cytokines. As we know, the major function of the receptor is to regulate the intracellular mechanism. So once the cytokines, they go and attach to the receptors which are present in the dendritic cells or the Langerhans cells, they help in movement of this dendritic cells into the deeper cells, deeper layers of the epithelium, that is into the connective tissue. Once they reach the connective tissue, that there is migration of this dendritic cell, there will be maturation of this migrating dendritic cells. That is, it starts maturing, and once it starts maturing, this mature dendritic cell, it engulfs the antigen and becomes an antigen presenting cell. And once this forms an antigen presenting cell, what happens is this antigen presenting cell moves to the specific regional lymph nodes, where this lymph nodes, as we have seen in the beginning slides, that lymph node is one of the a secondary lymphoid organ which is involved in the immune system. It usually acts as a barrier for the foreign antigen, that is, it filters them away to enter into the deeper tissue. This is what happens in the function of the dendritic cell as an immune system cell. Coming to the next set of cells, that is the natural killer cells. Usually, as we have seen, the natural killer cells, they have two receptors on them. One is the activating receptor and the other one is the inhibiting receptor. This activating receptor, as the name itself suggests, once there's any attachment of the antigen to this cell, it activates the receptor and further regulates the mechanism which is supposed to degrade the foreign antigen, that is the receptor. Whereas the name itself suggests the next set of receptors, that is inhibitory receptors, they inhibit the mechanism of the antigen regulation, that is further degradation of the antigen. So coming to the schematic diagram and diagrammatic representation of the functioning of the natural killer cell, as we can see in the picture, that it contains both the activating receptors and the inhibiting receptors. These activating receptors, usually on the normal cell, they get attached to the ligand for the activating receptor or the specific inhibitory receptor. Once they get attached to this ligand on the present on the normal cell, then say suppose if the antigen is a viral infection or otherwise a malignant transforming antigen, they cause the transformation of the normal cell, because as there is attachment of this receptors to the ligands of the normal cell, they transform the normal cell, and then they cause the inhibitory receptor. They start showing their effect based on the receptors which have a predominant effect on it. Suppose it's an inhibitory receptor, it stops its further progression. Suppose it's an anti-activating receptor, it progresses the attachment of the antigen to the antibody and causes a further degradation of this complex, and therefore results in cell killing. Coming to the major histocompatibility complex, which are the major, as the name itself suggests, they are the major organs, major receptors or the major antigens which help in regulating the immune function. Since they were first identified in a human leukocyte antigen, it is also known as human leukocyte antigen complex. This human leukocyte antigen complex usually has three classes, that is a class 1, class 2 and class 3, based on their location and also based on the presence of the specific receptors or the antigens. Coming to the first set of class 1 major histocompatibility complex, usually this class 1 MHC factors are usually located in human leukocyte antigen A, B or C, and they usually contain certain CD, they show the expression of CD8 plus lymphocyte receptors, and they identify this specific class 1 antigen which belongs to the CD8 plus lymphocytes. Coming to the class 2 MHC complex, they usually located on HLA-D region, that is a human leukocyte antigen D region, and usually they contain 3 loci within them, that is they are located in 3 locations within this HLA-D, that is they are presented at the DR region, DQ region as well as a DP region. And usually The major function of this class 2 MHC is they identify B cells, and further they cause the activation of this B cells which carry the CD4 cells, that is the T helper cells. So they function in mediating the identification of the B lymphocytes as well as the T helper cells. Coming to class 3 MHC factor, they are the components of the complement system, that is they cause the activation of the complement cascade system, which are usually help in destroying the formed antigen antibody complexes. So usually they are coded on the HLA complexes, and they are not actually related to the not associated with the HLA expression and antigen identification, but rather they cause a direct destruction by activating the complement cascade activation. This is what is a major histocompatibility complex. Coming to the role of the HLA system in the human system, firstly, the major function is in organ transplantation. Usually the recipient which contains this specific HLA complex is being identified by the recipient, that is they differentiate between the self and the non-self antigens. So by identifying the self and non-self antigens, they only accept the self antigens, whereas they do not accept the non-self antigens, by further preventing the complications in the organ transplantation. Coming to the regulation of the immune system, you usually have the class 1 and the class 2 MHC factors. Usually they identify the specific antigens, and further they mediate this immune regulatory system in both in cases of cell mediated immunity or otherwise humoral mediated immunity. This is what the function is, the role of the HLA system. Coming to the other one, they are associated with few diseases such as the autoimmune diseases. In say about in systemic lupus erythematosus, they have identified the presence of this HLA, and even in certain inflammatory diseases such as rheumatoid arthritis. But the exact mechanism of this association with the HLA with this specific disease is not yet being identified. Coming to next set, that is the autoimmunity. Autoimmunity, it is usually the antibodies which are being produced to the self tissues. That is the self tissues which usually recognize an antigen in a minor levels. This antigen, which is supposed to be neglected, but rather to this the human body system, that is a certain host cells, they identify them as a foreign antigen and they start producing the antibodies in a increased level. Thus since the foreign antigens are really not harmful to our body, the antibodies which are being produced specifically to the antigen, they act as an autoantibodies, and they form harmful substances to our body itself. So this is what is autoimmunity. So autoimmunity is actually the failure of the immune system to recognize itself and non-self antigens. That is the host immune system. It tries to recognize the self antigens and differentiates to recognize the self as well as the non-self antigens. Rather, it recognizes them as an antibodies and forms an recognizes them as the antigen and forms an autoantibodies. So this is known as autoimmunity. Autoimmunity is usually we see that immune tolerance, that is usually normally a human system has a capacity and an ability to recognize and differentiate between self and non-self agents in our body. But whereas in autoimmunity we see that there is failure. So and they rather recognize the self antigens as foreign antigens and form the autoantibodies. And usually the immune system has three major mechanisms. One is the clonal elimination, that is the T cells in the thymus, once they differentiate, they usually have a capacity to identify between the self and the non-self antigens. Once these T cells recognize the and differentiate between the self and non-self antigens, these T cells have finished their function and they are driven to the apoptosis, that is they are eliminated from the human immune system. This is what is means in clonal elimination. Coming to the clonal concept of the clonal energy, that is we see that the T cells which have purpose their function, that is once they have finished their function, they are not eliminated but rather they are being suppressed, that is they become non-responsive and they are being suppressed. This is what happens in the mechanism, that is the concept of the clonal energy. Coming to the suppressor T cells, that is, we see once our T cells, they have served their function, they are being suppressed. That is, they become cytotoxic to the host immune system by producing the T suppressor cells, which actually remove these cells by an antibody dependent cell mediated cytotoxicity. This is a major mechanism which we see in immune system, but whereas in autoimmunity, we see that there's alteration of all these systems. Autoimmunity, majorly we see it could be because of the immunological factors, that is presence of polyclonal activation of the B cells. That is, when the B cells, they get activated and they bypass the T cell tolerance, this results in autoimmunity by production of autoantibodies. It could also be because of the self-activation or self-reactive B cell formation. That is, the B cells, they are so many in number, that is, they dominate the T cells and they bypass the T cell activity by forming the predominant cells and resulting in the formation of autoantibodies. This is what we see in cases of immunological factors. Other than that, we also see that there is a decrease in the T suppressor cells population and increase in the T helper cell population, which usually help and regulate the further activity of the immune cell and suppress the unwanted cells. This is what happens in autoimmunity in case of immunological factors. Coming to the genetic factors, it has been identified that in certain autoimmune disorders, there was increased expression of the class 2, which is majorly involved in autoimmunity. This was found in the genetic factors in cases of autoimmunity. Coming to the microbial factors, autoimmunity has been associated with certain microbial factors such as the bacterial or well as or otherwise the viral factors. This is the major reason why autoimmunity has developed, but the clear molecular mechanism for the development of autoimmunity has not yet been recognized. Coming to the autoimmune disorders, they can be further divided into organ non-specific or otherwise organ specific. That is, organ non-specific, they are not specific to a particular organ, but rather they can be seen diffusely or widely distributed throughout the bodies. And amongst them, the first one is the systemic lupus erythematosus, which is widely distributed throughout the body, and they are not specific to a particular organ. And the other ones comes the rheumatoid arthritis, Scleroderma, Joggers Syndrome, and venous granulomatosis. These are few illustrations of the organ non-specific autoimmune disorders. Coming to the organ-specific localized immune disorders, which are specific to the endocrine glands, they are the Hashimoto's disease, Graves' disease, type 1 diabetes mellitus, idiopathic Addison's disease. Coming to the next set of disease, which are localized to the alimentary canal, alimentary tract, they are the autoimmune atrophic gastritis in case of pernicious anemia, and then comes the ulcerative colitis and the Crohn's disease. And the other and the blood cells, the autoimmune disorders include autoimmune hemolytic anemia or the otherwise autoimmune thrombocytopenia and pernicious anemia. Coming to the others, which are not specific to a particular organ, but they can be seen only attacking specific tissues, that is myasthenia gravis, which affects the muscle tissue, and the autoimmune skin disease, which are dermatological disorders. Coming to the mechanism, the proposed mechanism, but not the exact mechanism. Usually we see autoimmune disorders, usually it could be familiar, that is inherited disorders from the genetic susceptibility. Suppose that genes are susceptible with certain alterations in the specific genes, it could be because of the chromosomal deletion or otherwise chromosomal translocation. We see that there's failure of the self-tolerance, that is a failure of the recognition of the self-antigens and non-self antigens, by which these become self-reactive lymphocytes. Once they form the self-reactive lymphocytes, these result in the formation of the activation of the self-reactive lymphocytes, which are toxic to the human system, and they form they form the basis for the autoimmune disease by formation of autoantibodies. Whereas we see in cases of specific conditions like infection or inflammation, we see once the infection tissue is being infected or there's inflammation of the tissue, then this tissue they causes the activation of the antigen presenting cells. This antigen presenting cells cause the activation of the T lymphocytes, as we have seen in cases of the functioning of the T lymphocytes, that once there's antigen presenting cells, these activates the T lymphocytes and they cause the influx of the self-reactive lymphocytes, which results in activation of the self-reactive lymphocytes as to become cytotoxic to the human host immune response, and they form the basis for the autoimmune disorders. That's what happens in autoimmunity. Coming to hypersensitivity, it is the exaggerated response to the of the host immune system. That is, it is an exaggerated, increased response to any foreign antigen. Usually, it is a antigen-antibody reaction, and it is classified into two types, that is a delayed type and an immediate type. Among the immediate type, we see that there's type 1, type 2 and type 3 hypersensitivity reactions, whereas in the delayed type, we see that there's type 4 reaction. In the immediate type, we see once there's an exposure of the host to the any antigen, we see an immediate hypersensitivity reaction that is within few days or within few hours we see there's a reaction. But whereas in delayed type we see that there is a delay in the hypersensitivity reaction, which might take a time period of approximately hours to weeks. Coming to the brief description of the types of the four types of hypersensitivity reaction. There are four types, that is the type 1, type 2 and type 3, type 4 reaction. The first one, it is an immediate type of hypersensitivity reaction, also known as anaphylactic or atopic reaction. It is mediated with the help of certain particular immunoglobulins known as immunoglobulin A antibody. So once there's exposure or contact with the antigen with the this specific antigen exposure to the specific cell, this antigen exposure this releases causes the activation of the IgE immunoglobulins, which act as a receptors, and they cause the activation of the intracellular mechanism. That is, they start secreting the plasma cells. Once there's exposure or binding of the antigen to the antibody, then they start releasing the plasma cells. This plasma cells, they release the immunoglobulin A antibodies, since they are specific to the cell surface receptors. So once there is a release of this antibody, they cause the activation of the basophils or otherwise the mast cells. These basophils or mast cells, as we know, they contain specific granules within them. These granules they cause the activation of the further mechanism, and they cause the binding of this antigen to a particular fragment of the antibody that is known as constant fragment. There's this antigen, once it goes and binds to the constant fragment, it forms an interlink between the further antibody reactions and causes this further link, that is the formation of the antigen to the specific component on the antibody, that is a constant fragment. It causes the activation of the mast cells. Once these mast cells or the basophils, they get activated, as they are known as granulocytes, they contain certain granules within them. They release this, there will be degranulation of this mast cells and basophils. These granules, which contain histamine and heparin, which act as vasoactive amines, they cause the vasoactivation, that is, they cause the vasodilation, by which there will be formation of edema in such cases of hypersensitivity reaction. This is what happens in type 1 hypersensitivity reaction. Coming to the type 2 hypersensitivity reaction, it is also known as a cytotoxic reaction, where we see once there's binding of the antigen on the target cell, this binding of the antigen on the target cell, it forms the antigen-antibody complex. This antigen-antibody complex, it will cause the, it will bind to the particular fragment, that is again comes a constant fragment which is present on the antibody, and this antigen-antibody complex formation, it forms as a link, and it starts the activation of the complement cascade activation. This complement cascade activation, once it gets activated by the formation of this particular binding of the antigen to the constant fragment, this as the complement cascade activation, it is directly involved in damaging the target cell which is being affected, unlike that of the lymphocytes or the cell mediated immunity. There will be lysis of this target cell. Once there is lysis of this target cell, there is phagocytosis of this lyse cell, that is macrophages, they engulf this lyse cells, and this results in cell eating. This is what happens in type 2 hypersensitivity reaction. Coming to the type 3 hypersensitivity reaction, similarly we see that as type 2, there is also antigen antibody binding and result in the formation of antigen antibody complexes in type 3 hypersensitivity reaction. Further, there will be activation of the complement activation, we see. Then once there's activation of the complement activation, there's deposition of these antigen antibody complex. They are not being lysed in cases of type 3 hypersensitivity reaction. Rather, there'll be degradation, deposition of this antigen antibody complex on the vessel wall. Since the target in type 3 hypersensitivity reaction are the blood vessels, these antigen antibody complexes, they get deposited in the vessel wall, and they cause inflammation of this vessel wall by destructing the tissue. That is, they cause end arthritis, skull-like conditions in case of type 3 hypersensitivity reaction. Coming to the type 4 hypersensitivity reaction, once the antigen bounds to the specific target cell, then there's activation of the T suppressor cells, that is the CD8 plus, which are being antigen presenting cells, which act as an antigen presenting cells. There's activation of these cells in cases of type 4 hypersensitivity reaction. This is what the picture shows, that there's antigen, they engulf the antigen and they act as antigen presenting cells by the activation of CD8 plus T cells, that is the T suppressor cells. Once they act as antigen presenting cells, these cells along with the engulfed antigen, they start migration of the antigen from the particular specific region where they are modified into antigen presenting cells. They move towards the lymph node. In the lymph nodes, these antigen presenting cells, they are being filtered, since lymph nodes act as a barrier for the host immune system by recognizing the antigens and destroying them and preventing them from further invading into the underlying tissues. The antigen presenting cells in the lymph nodes are being filtered, and these antigen presenting cells, once they are filtered, these are being destructed by the activated T cells and as well as with the macrophages. This is what happens at type 4 hypersensitivity reaction. So coming to the time period when the hypersensitivity reaction starts showing its effect, in type 1 we see usually it starts within 15 to 30 minutes, and it's a similar time within type 2, but whereas in type 3 we see the duration is within 6 hours, and in the case of type 4, after the exposure of the allergen after 24 hours of exposure, the type 4 hypersensitivity reaction starts showing its effect. And coming to the mediators which mediate this hypersensitivity reaction, in case of type 1, it is the IgE, whereas in type 2 and type 3, it is the immunoglobulin G and immunoglobulin M, which are immunoglobulin gamma and mu. Whereas in type 4, it is a cell-mediated immunity by CD8 plus T cells. Coming to the illustrations of this type 1, it is in cases of local anaphylaxis and systemic anaphylaxis. Since it is also known as anaphylactic or atopic reaction, type 1 hypersensitivity reaction, we see in case of local anaphylaxis, such as in cases of any exposure to allergen or pollutant, whereas in systemic anaphylaxis, we see when there's any drug administration, we see type 1 hypersensitivity reaction. Coming to type 2 hypersensitivity reaction, which is also known as cytotoxic reaction, it is usually because of any cytotoxic exposure in cases of immune disorders, or otherwise even in cases of such as other certain immune responses which usually behave by activation the self-reactive T lymphocytes. That is, when the T lymphocytes, that is the increased in quantity in cases of cytotoxic, then there's this cytotoxic mechanism activates. That is a type 2 hypersensitivity reaction. Type 4 hypersensitivity reaction, which is an antigen antibody complex reaction, we see that it mainly seen in blood transfusion cases of reaction, or otherwise in cases of autoimmune hemolytic anemias, in cases of systemic lupus erythematosus. These are the conditions where we see type 3 because of the development of autoantibodies. Coming to type 4, usually we see in cases such as when there is any destruction of the tissue because of increased self-reacting T lymphocytes presence. This is what explains the type 3 all the types of the hypersensitivity reaction. Coming to the disease of immunity, usually we see that they are grouped into four groups based on the immunodeficiency disorder. That is, as we have seen, that there's failure of the host immune response to properly function to its maximum limit because of any alterations, either because of the genetic alterations or otherwise because of any acquired alterations. The major illustration which can be given in immunodeficiency disorder is AIDS, which is an acquired immunodeficiency syndrome because of the reduction in the CD4 plus T lymphocyte count. And the other hypersensitivity reaction, the second group is hypersensitivity reaction. That is, there's hyper reaction or the hyper functioning of the immune system, which we see in hypersensitivity reaction. In the previously explained slides, we see that the hypersensitivity reaction with their associated illustrations. Coming to the autoimmune disorders, that is the failure of the immune system to recognize self and non-self antigens results in autoimmune disorders. An illustration of systemic lupus erythematosus, scleroderma, Wegener's granulomatosis can be given. Coming to the possible immune disorders, the exact mechanism of this immune disorders is not known, but it could be because of any alteration in the regular host immune mechanism. An illustration of this can be given as amyloidosis, where an insoluble protein is formed. Insoluble fibrillar protein is formed because of the improper degradation of proper digestion of this protein. We see in amyloidosis. These are the four groups of disease of the immunity. Coming to the major immunodeficiency disorder, that is AIDS, which is known as acquired immunodeficiency disorder, and which is caused by a human immunodeficiency virus, which is a retroviral disorder. And this is usually caused, this is of two types, HIV virus 1 and HIV virus 2. HIV virus 1, usually we see HIV virus 1 causing HIV AIDS in cases of in certain areas, that is United States as well as in central part of Africa. But whereas HIV2 we see in west part of Africa as well as in certain parts of India. This is what is a brief description of HIV and its affected. And usually in certain major immunodeficiency disorders, the HIV is the most commonly seen disorder which affects the humans with such the immunodeficiency disorders. Coming to the structure of the HIV virus, usually HIV virus consists of core protein. This core protein, which consists of the viral RNA genome, that it consists of two strands of viral RNA genome. As we can see in the central part, this viral RNA genome, it is being coded by protein P24 and protein 18, known as P18. So these are the two strands, and this viral RNA genome also consists of is being enclosed within a proper envelope, which this envelope consists of glycoproteins GP120 and GP41. So this GP120 and GP41 make up the lipid bilayer membrane, which encloses the envelope, which encloses the virus. And this outer layer of the lipid membrane is being derived from the host cell, that is the host cell which is being infected. This forms the outer layer lipid membrane, whereas the inner lipid membrane is being derived from the virus itself. And other than that, we can see even the presence of matrix proteins and the presence of certain group of enzymes known as proteases and reverse transcriptase, which is actually encoded with a POL gene, and this gene usually helps in the formation of an identical strand of the DNA host genome. And the other one enzyme is integrase enzyme, which helps in integration of this host of the viral DNA and the RNA into the host DNA genome. So this is what they have as a function of the integrase enzyme or the gene. And the other one is TART gene, which is a transcriptor activation gene. That is, it causes the activation of the formed complementary DNA strand. It activates this formed complementary DNA strand. And the other one is the nucleocapsid, that is, which encloses the viral RNA, and the entire core protein is being enclosed within a capsid. This is what is the structure of a virion. Coming to the routes of transmission, or the major routes of transmission for this HIV is, first one is the sexual transmission. It could be either from a male to male, or it could be homosexual, or otherwise a heterosexual. And coming to the next transmission, it is via the blood and the blood products, usually in case of blood transfusion, or otherwise because of any unfortunate contact with the syringes or needles or the scalpels or blades of the already infected patient. It could also be because of the perinatal transmission, that is a transmission from the maternal, that is during the birth, or because of the transplantal exchange of the fluids. It could cause the one of the possible route for attaining the HIV infection. The other one is occupational transmission. That is in cases of mostly in cases of doctors we see because of an unfortunate injury in treating an HIV patient. This could also be one of the reasons where dentists are more prone for this HIV. The other one is the transmission of the other body fluids. It could be because of the accidental exposure to the patient's body fluids in case of blood transfusion, or otherwise the hemofluids, or in case of cough and all those. These are routes of transmission. Coming to the pathogenesis, usually there are certain phases of the pathogenesis, and firstly, as we have seen that GP120 plays an important role in attaching to the host target cell, and the most important target cell usually in a host is the DNA. Starting with the HIV, as the HIV is being exposed to the host DNA cell, it gets attaches to the receptors. These receptors, the host, the HIV cell usually has tropism for CD4 plus T cells which are present in the host cell. So once this CD4 cell is being recognized by the HIV, it goes and binds with the help of GP120. GP is an abbreviation for glycoprotein 120. So once it has a tropism for the CD4 plus cells, it goes and attaches. This is mediated with the help of chemokine receptors, which is a co-chemokine receptors. This chemokine receptor, it usually mediates the binding of the glycoprotein 120 with that of the CD4 plus T cell which is present on the host cell. Once there's binding of this host cell with the HIV, it starts integrating, that is, it moves into the cell. This movement is known as, once there's fusion, the first stage is fusion, that is a binding, next the fusion with the host cell, then it is movement of the host cell, that the main, as we know that the target is a DNA genome, there will be a viral RNA starts moving towards the host DNA genome. This before it moves to the host DNA genome, this viral RNA, it's with the help of the presence of the reverse transcriptase enzyme, it synthesizes a new DNA of the new RNA, that is a complementary strand. Once is a complementary, that is a two strands of RNA have formed. This RNA forms, they start resulting in the formation of the DNA of the, that is a complementary strand which matches with that of the DNA. Once this DNA has been formed, which is complementary to that of the host genome. This, along with the RNA, it gets integrated with the RNA strand, and then it starts moving to the host genome. Then once it starts moving with the help of the integrase enzyme or the integrase gene, it starts moving to the host genome, and in the host genome, this RNA as well as the DNA of the HIV virion, they integrate within the host genome DNA as well as in the extracellularly present RNA. And once this is incorporated within the host DNA genome, then this starts moving from the host genome into the extracellular. That is, it starts moving away from the nuclear part and to the within the cytoplasmic region. And there is movement, as we can see, that is movement of the integrated host and the viral DNA into the away from the nucleus. That is, there will be translation to the protein. So this is being carried for the further protein synthesis. These, as DNA carries a sequence for the protein synthesis, the DNA or infected DNA, since it has an integrated part of the virion or the provirus which has been formed, this is moves this. Codes for the further protein synthesis. So once the viral DNA has been integrated into the host genome DNA, this is being transferred from this genome to the outer extracellular region, that is the cytoplasmic region. So once the formed integrated viral DNA genome along with the infected target cell is known as a provirus. This provirus, it starts moving, and then it since our DNA carries a sequence and the message required for the protein metabolism, it also interferes with the translation and the transcription process. Once it moves out of the nucleus, then With the help of protease, it cleaves a viral polyprotein and then results in the proliferation of this viral genome or the provirus. There will be proliferation of the viral genome, and once this starts proliferating, it targets the major first line of cells which are being targeted with this HIV virus, the CD4 plus T cells. Once the CD4 plus T cells are being targeted and they start getting destroyed by this infected cell, and they start decreasing in the number in the host immune body. So once this starts decreasing, there's a compromised host immune response now because of this infected virus cell, and this results in dissemination. That is this since the virus there's no control of this infected cell in the body, that starts spreading throughout the entire body along with the body fluids, or otherwise the any through any pores within the organs. So once the virus starts spreading within the body, it also starts targeting the other immune cells. It could be the natural killer cells or the B cells or the other macrophages. Because of this, the entire immune system is being hampered and it is compromised completely, and this results in proliferation. This results in further replication, and it starts giving off new infected virions, that is a newly formed infected HIV cells. They start growing from this already infected primary cell, and they start budding off. That is, they give rise to new cells, then they cut off from the parent cell and they get transfer. They move throughout the body. This is what we can see in cases this. At first, there is binding of the GP120 with the host CD4 plus cells. Since there's tropism, then there's uncoating of this viral genome. Once there's uncoating, then there's integration into the host genome. Then there's a bind. Then once that's integrated, it forms the provirus, and this provirus, it is released extracellularly. Then is targets the CD4 plus cells. After the targeting the CD4 plus cells, we see the next stage, that is a dissemination, that is a spread of the already formed viral particles. Once it is disseminated, we see that the other immune cells are being targeted. Once they are being targeted, there is a more of viral replication, and then it the final stage, other than the non-lymphoid organ involvement, there is a involvement of the central nervous system, where the other cells known as oligodendrocytes or the astrocytes or the glial cells, they all get affected because of this mature virion. This is what is the pathogenesis of happening in the HIV. Coming to the phases of what happens in the HIV is divided into three phases. First is the early or acute phase, that is after 3 to 6 weeks of the exposure to the HIV virus. In this phase, we see usually there are skin rashes and mild fever, malaise, body pains can be seen. Whereas the CD4, since CD4 plus T cells are the target cells, there's decrease in the CD4 plus T cells. It could be it could reach 500 or must be a little higher than that rate. And the other one, there's the next stage coming to the middle or chronic stage. Usually it is ranges from 10 to 12 weeks after the exposure. We see that the CD4 plus T cells, they range from 200 to 499 per microliter. Next, coming to the final or the crisis stage, that is a stage where the HIV is completely accumulated, or HIV virions are completely accumulated in the host. That is, it may range from any period up to death, and usually the CD4 plus count, CD4 plus T cells, they are usually below 200 per microliter. This is an indicator that the patient is an AIDS patient. So the Center for Disease Control has been organized in US. This has usually grouped the patients into category A, B, and C. First category has grouped the patients into category A, groups the patient into asymptomatic infection. Since in the first phase, that is in the early or acute phase, patient is asymptomatic without any symptoms. Rather, patient might show persistent generalized lymphadenopathy, and this stage is known as acute HIV syndrome. Then coming to the next stage, that is a mild chronic syndrome. Mild chronic stage, where it is being categorized as B. We see that there is symptomatic disease, certain disease we can see, and other than that, there is a secondary to the impact of the cell-mediated immunity. Coming to the third category, that is the category C, we see that there is presence of completely AIDS signs and symptoms, which will be further discussed. This what are the phases of the HIV. So coming to the acute HIV, we see usually starting with the systematic, we see the fever and unexplained weight loss in the patient, and there's pain in the mouth, pharynx, that is results in pharyngitis, which would involve sores in the mouth, and otherwise even sore throat can all be also seen. Other than that, candidiasis is also a chief as also a chief symptoms which can help us to recognize the patient as an AIDS patient, that is known as candidiasis thrush. And when it involves the esophagus, there are sores or ulcers which can be formed. And coming to the muscles, myalgia, that is a pain, muscular pain can be seen. And liver and spleen, when it is involved, there's enlargement, that is lymphadenopathy can be seen. And when it involves the central nervous system, we see that there's malaise, headache, and otherwise neuropathy is also be seen. And in the lymph nodes, that is a regional lymphadenopathy can be seen. And in the skin, there's rashes. And when it involves the gastrointestinal tract, there'll be nausea and vomiting. These are the symptoms which can be seen in acute HIV. Whereas in the main symptoms, that is in the mild or mild chronic phase or the adaptive or the progressive AIDS, we see that the central nervous system, we see that encephalitis as well as meningitis, whereas in the eyes we see causing retinitis, and lungs we see pneumocystitis, pneumonia, and otherwise TB can also be seen. And other lung tumors can also be seen affected. Skin, there can be tumors which can be seen, that is in the initial stages, that is the benign tumors which are being superficially seen can be seen. And the gastrointestinal tract, esophagitis, esophagitis, gastritis, as well as certain other tumors can also be seen in an adapted or a chronic phase of AIDS. Coming to the test for establishing a diagnosis of HIV, firstly we have to see a test which establishes the presence of infection. For that, the antibodies have to be detected. For that, enzyme-linked immunosorbent assay is a test which identify the antibodies for GAG and ENV. That is the antigens. GAG, which codes which shows the expression of the presence of the core protein of the HIV virion, and ENV gene, which shows the presence of the envelope which constitutes the glycoprotein GP120 as well as 40. That is the presence of the host virion. The presence of these antibodies, expression of antibodies for these genes or the antigens is being expressed by the enzyme-linked immunosorbent assay test, where we see that exact confirmatory test cannot be confirmation cannot be that the patient is an HIV, but rather it could persist as a screening test. Then once ELISA is positive, then we can go for a Western blot test. Western blot test, it recognizes the antibody for the GAG, ENV, as well as POL gene, and other than that, the transcription activator gene, that is which helps in transcription of the RNA of the HIV. So we can see the expression for all the 4 genes in case of Western blot test, and presence of the antibodies for these 4 genes gives a confirmation that the patient is a HIV patient. And the other test, once the patient has been confirmed, then there's a direct detection of the HIV. That is, the patient can be detected by the culture of the HIV virus by taking from the body fluids of the patient, or otherwise P24 antigen can also be recognized, which is a major component of the host viral RNA. Once infection has been established that the patient has a HIV infection, then the further detection for the immunity is seen. As we see that the CD4 plus cells are the major cells which have tropism for this HIV viral. There's decrease in the CD4 plus T cells, as we have seen in the phases, that is in the early, acute, and the mild, and whereas in the advanced stages we have seen that the decrease in the numbering and the total count of the CD4 plus T cells. They serve as a one of the agent to identify the stage of the AIDS patient. So that CD4 T plus cell is completely fallen. That is in the advanced stage, as we have seen, the decrease below 200 means that the patient is a particular age patient, a confirmatory of the age patient can be given. Then the CD8, since the ratio of the CD4 plus cell to the CD8 plus cell is 2 is to 1, that is the CD4 plus cells are usually twice the number of CD8 plus cell in a normal human host system. But in this case, in patients, we see that the CD8 plus, there's a reversal of the CD4 plus to CD8 plus ratio. That is CD8 plus predominant, that of the CD4 plus cells. So it is reverse. Coming to the test for the detection of the opportunistic infection and the secondary tumors, as we have seen, certain opportunistic infections, that is the bacterial infections or the fungal infections, can be seen, such as the candidiasis. So FNAC of the particular size, that is a fine needle aspiration cytology of the fluid. The fine needle aspiration cytology can be done where the fluid is being aspirated from the body, and this fluid is being observed. After being processed, is being observed under a microscope for the presence of particular bacterial or the fungal microorganisms, where we can give the diagnosis of particular opportunistic infection. And in cases of tumors, a biopsy, that is a gross specimen, is being taken and processed, and the diagnosis of the particular tumor can be given, whether it's a malignant or otherwise the benign tumor. These are the diagnostic aids for HIV. Coming to systemic lupus erythematosus, it is an autoimmune disorder which was previously known as termed as lupus, because it is derived from a Latin word. Lupus means wolf. Since in systemic lupus erythematosus, they have identified the skin was being destroyed completely. That is like as a wolf eats skin, so it was termed as lupus. And this systemic lupus erythematosus is being divided into two types, that it could be systemic or disseminated, or otherwise discoid form. Coming to systemic and disseminated form, when the lesions, skin lesions or otherwise involvement of the other body parts, when it is widely distributed, then it is known as systemic or disseminated form, and this also shows the presence of autoantibodies. Coming to the discoid form, this discoid form, the rash in the form of a disc-like that is extending from the cheekbones to the nasal bridge, this has brought the name that is a discoid form. So the butterfly rash is the most important characteristic feature of the systemic lupus erythematosus. Coming to the etiology of systemic lupus erythematosus, we find they have found that there are certain anti-nuclear antibodies. These anti-nuclear antibodies are the autoantibodies which have been found for the cell's own nuclear and cytoplasmic proteins. That is, it could be a autoantibody for a DNA, RNA, or otherwise the cytoplasmic proteins in the body. So the presence of this anti-nuclear the presence of this anti-nuclear autoantibodies has been recognized as one of the pathological mechanism or etiological factor for the development of systemic lupus erythematosus, but the exact mechanism has not yet been discovered. So these antibodies, they could be antibodies to the double-stranded DNA, or otherwise they could be for the RNA also, and they could be also for the Smith antibodies. That is, Smith is a region of the ribonuclear protein, that is the envelope of a ribonuclear protein. So this antibodies to even to this Smith membrane have also been identified in case of systemic lupus erythematosus. Coming to the other non-specific antibodies is antibodies to the ribonuclear proteins, or otherwise to the other cytoplasmic proteins to the ribosomes have also been identified. So this has been one of the possible mechanisms for the development of systemic lupus erythematosus. Next, coming to the pathogenesis, they have identified that the pathogenesis, since there was type 2 type of hypersensitivity reactions, so they have identified this could be one of the pathogenesis, or otherwise type 3 hypersensitivity reactions, since there was antigen antibody complexes which have been formed and identified in the blood vessel wall. So this could be one of the pathological mechanism by the systemic lupus erythematosus has been arrived to. And coming to the major clinical features, what is being observed is, first thing, since it's a skin first identified as a skin disorder, they have identified the skin lesions such as known as butterfly rash has been observed, where the rash extends from the cheekbones and covers the nasal bridge. So this has been one of the characteristic features as already explained. Coming to the systemic symptoms. Low-grade fever as well as photosensitivity has been observed among the patients, and there was observation of the involvement of the mouth and nose with formation of ulcers in these mucosal areas, and there was muscle aches, that is myalgia was present, and there's joint aches, that is the arthritis has been also observed among these patients, and there were psychological disorders. With loss of appetite and fatigue in the patient. And coming to the inflammation, there was pleuritis, that is inflammation of the pleura, and pericardium, that is the pericarditis has been observed. As other than that, the fingers and the toes were observed with poor circulation, and there was also presence of Raynaud's phenomenon in such kind of patients. Coming to the diagnosis of SLA, there was being of a particular diagnostic criteria has been given, that is presence of 4 or more clinical signs of the following symptoms only. Based on these symptoms only, the patient should be diagnosed as a systemic lupus erythematosus patient. Coming to the these criteria, they include the malar rash or the discoid rash, photosensitivity and presence of oral ulcers, and non-erosive arthritis, serositis as pleuritis or otherwise pericarditis, renal manifestations, which could involve the lesions in the kidney, or otherwise neurological, that is the psychological disturbances, or hematological derangements or immunological derangements, or otherwise presence of antinuclear antibodies. The presence of 4 or more of these symptoms and signs and the clinical features, only a patient could be diagnosed as systemic lupus erythematosus. Coming to the other autoimmune disorders, that is the scleroderma, which is also known as progressive systemic sclerosis. As the name itself suggests, scleroderma. If we split the name, sclero. That is sclerosis or formation of fibrosis of the derma, that is the skin. So since it was the first previously observed as a skin disorder, with formation of skin rashes, that is, it would firstly the clinical features included firstly involvement of the proximal part of the fingers, which could involve next gradually progress towards the hands, then towards the neck, shoulder, and then the face. So these were the skin lesions which were observed, and usually the patient would appear as a face mask-like or otherwise claw-like, and there are two main types of this scleroderma. The one which is only diffuse, which involves only skin lesions, whereas the other one is a crest syndrome, which shows crest stands for calcinosis, wherein crest syndrome, that is C stands for calcinosis, R stands for Raynaud's phenomenon, E stands for esophageal hypomobility, and S stands for syndactyl, and T stands for telangiectasia. So this group of conditions has been observed in a scleroderma patient. So they have classified it into diffuse scleroderma or crest syndrome scleroderma. So so in these patients they have identified the presence of autoantibodies, so which has made this come under autoimmune disorder. Next, coming to the Joggers syndrome, this is one of the syndrome showing the triad, that is the presence of skin lesion, the presence of eye lesions, mouth lesions, as well as rheumatoid arthritis. That is, there was presence of dry eyes, which could result in itching, blurredness of the vision, or otherwise xerophthalmia. And the other mouth lesions, it could involve dryness of the oral cavity, where it was leading to the complication of difficulty in dysphagia, that is swallowing, dysphagia, and otherwise oral ulcers are also be seen, and rheumatoid arthritis has also been seen. And these patients are there are only few patients which have showed the presence of autoantibodies, so this is being classified as one of the autoimmune disorder. Coming to the next one, it is a polymyositis, dermatomyositis. It is a combination of muscular weakness as well as the skin lesions. This condition has also been shown the presence of autoantibodies, by which it has been classified under autoimmune disorder. Coming to Rita syndrome, it is a triad of urethritis, conjunctivitis, and ulcerative colitis. So this syndrome also showed the presence of autoantibodies, so it has been classified under the autoimmune disorder. So this finishes the autoimmune disorders.